Good afternoon. I am Dr. Christopher Oliveros. Today I am tasked to give to you a lecture on Neuro Ophthalmology. Actually, the lecture is lifted basically from your reference or textbook. I think that's basic ophthalmology from yung white one. So it's just a summary of the two chapter. So everything I mentioned here is actually there. Pero may mga, there's a little bit of injections of some inputs from other sources. Okay, so can you see me or just my screen? Okay, sige. So good afternoon. Today we will talk about neuro-ophthalmology. It is the subspecialty that merges the fields of neurology and ophthalmology. It is the subspecialty which is that deals with the visual disturbances resulting from disorders of the central nervous system that affect the vision, control of eye movements, or pupillary reflex. So, just a few basic information we need to know is that 6 out of the 12 cranial nerves are involved with the functioning of the eye or the ocular reflex. Just as with other portions of the nervous system, the neural pathways involving the ocular system can be separated into the afferent and the efferent pathways. The afferent pathway involves the optic nerve, cranial nerve 2, while the efferent pathway involves cranial nerve 3 or 6. The sensation is transmitted by the trigeminal nerve, cranial nerve 5, and the facial motor function is conducted. 7th cranial nerve. In addition to this, the sympathetic nervous system contributes to the eyelid dilation. Okay, so first we will talk about the examination of the eye, which involves the vision and the eye movements. So we will start with visual acuity test. So visual acuity, as with any eye examination, is the first in the neuro examination to determine the patient's clarity of vision. So this is done by measuring the acuity of each eye independently. The Snell and Wall chart at a distance of 20 feet is the standard method of determining the acuity. For patients who are admitted and we have no access to the Snell chart, you can use the near card with good lighting. With good lighting. So in this first step, you usually start with, for uniformity, we start with the right eye, then record how far the patient can read to the smallest octotypes, and then record that, then go to the next eye, the fellow eye, the left eye, also record. So you will encourage the patient to read as much as he or she can, because sometimes patients tend to be a little bit hesitant or lazy to finish it. But the more they can read, more accurate yung visual acuity testing. So I guess this was already discussed with you. So somehow we will just browse through it. So for the visual field testing, this is one way to measure how much vision you have in either eye and how much vision loss you have occurred or the patient may have occurred. Visual field test can determine if you have blind spots, stoma in your vision, and where they are located. So stoma size and shape can show how eye disease or brain disorder is affecting your vision. So for visual field testing, this can be done through two ways. You have your perimetry or your automated visual fields testing, or in your clinics, you can simply do the confrontational testing. So, perimetry is the formal evaluation of your visual field. This is the more accurate way to check for visual field defects. Although it can be time consuming, it requires special training to operate the device or the machine that will, the perimetry machine. And of course, the equipment is expensive. It costs around 1 million. So, what we can do in the clinics is do the confrontational field testing. This is done in clinical settings, and it can provide us very useful information. Not as accurate, but if you do it well, it's close to the result that you may get doing the clinics. Okay, so how do you do the confrontational field test? So ask the patient, sit in front of you, test the eye separately. And then ask the patient to close one eye. Usually it's the right eye first that we test. So, when you are the examiner, you sit right across the patient, arm's length. And then if the patient's right eye is open and the left eye is closed, you will have to open your left eye, the other, the eye that's facing the open eye of the patient. Because you will have to test the patient through your own vision. So, it's like patient's right eye, and then the tester's left eye. Tapos, do the same also for the other. You present a random number of fingers in all the 4 quadrants. Then ask the patient if she sees or he sees the visual stimulus, and then record. In the areas where he or she cannot see the visual stimulus, pero you can still see it, it means there's a visual field defect in that area. Okay, so simple method for detecting yung central field defect is to ask the patient to look at a piece of paper or a graph paper or what you call the answer sheet. Have you seen one? It's like this one picture. So, and central scotoma might look like this one. So when you ask the patient, close your left eye and see through your right eye. But if the patient has a scotoma, he or she will not be able to see say there is an obstruction in the field of view of your central scotoma. Another method of testing is to have the patient fixate on your examiner's nose with one eye and ask the patient if there's any part of the examiner's face that is missing or obstructed or distorted. For color perception and saturation, 90% of the fibers of the anterior visual pathways serve the central vision, which is extremely sensitive to the color red. The peripheral retina, by contrast, is nearly blind to red. So, consequently, many diseases of the optic nerve and other anterior visual pathway structures will cause red hues to appear desaturated, like this red appear desaturated. You have somehow disease of the optic nerve. So the most common actually used is the pseudo-isochromatic color plates, or more commonly known yung Ishihara, Ishihara plates. This will test quantitatively for the red and green color deficiency. And as shown in this picture, another simple, quick method of testing color saturation is the red cap test. You ask the patient to compare the color of the red bottle cap from one eye to the other. So normal eye will obviously see it as bright saturated red, and if a fellow eye has an optic nerve disease, the cap may appear orange, pink, or brown. So ito, pupillary examination. This is one of the more important things you do for neuro-ophthalmology examination, is the pupillary testing the pupils. So pupillary size relates to varying interactions between the parasympathetic and the sympathetic pathways. Parasympathetic innervates the iris sphincter muscle that causes constriction or pneumosis. Sympathetic pathway naman innervates the iris dilator muscles that causes dilation or mydriasis. So sometimes it's confusing which pathway you constricts, which pathway dilates. So you can do some mnemonics. And now as a student, I used yung EC, parasympathetic constricts, the ST, parang EC and ST, sympathetic dilates. So for a proper pupil examination, you should do it in a dim room with a small bright light source. It could be a pen light, ophthalmoscope, or better yet yung friend's element. You should ask the patient to fixate on a distant object. Why distant object? Because when a patient focuses on a near target, the pupils constrict. This is part of the what you call the near triad. Present near target of the patient, the eyes will converge into the target and also constrict. So it may give you a false examination of the pupils. So dapat distant sa fixing. So patients should be fixating on a distant object. So in testing the light reflex, it should be in a dim room. You shine the bright light into each pupil slightly below or slightly temporal visual axis. There should be a brisk, simultaneous, and equal response of both pupils. Now, for pupils that react poorly to light, you should test pupil constriction with accommodation. Patient with both eyes focuses on a small, both eyes open, focuses on small, easily discernible target, moves slowly toward the face. So, in light near dissociation, the pupil that reacts quickly to light but strongly to accommodation is it's the eye that has the problem. It signifies an abnormality of the midbrain hemisphere. The swinging flashlight test detects RAPD, or the Marcus point, which is present when there is difference in the strength of light reflex. Swinging flashlight test, you just shine a light on one eye for 3 seconds and move rapidly across to the other eye for 3 seconds and then shift back. So you repeat this several times until you are certain of positive relative apparent pupillary defect or RAD is a repeatable dilation of both pupils without initial constriction as the light is swung in the normal eye. So an RAPE almost always indicates lesion in the optic nerve on the optic side. Defect in the apparent pathway sensory pathway towards the brain. It results in dilation. So in this picture, syempre, if you shine a light source on one eye, there should be the constriction of the pupil. In this case, you have an RAPD of the left eye. So when you transfer the light source to the left eye, then instead of constricting, the pupil is dilate. Okay, so when you go back to the right eye, it will constrict again. One more time to your left, it will attempt. So yun yung positive. So ocular motility test. So evaluation of patient with neurologic symptom is not complete without evaluation. I'm sorry, ocular motility testing. Eye movement should always be tested, especially if the patient has complaint of double vision. So these are the following various methods you can use to assess the ocular alignment and mobility. There's prisms, red filters, simple as the corneal light reflex position, which we're doing. So in this portion, you examine the following abnormalities. If there is strabismus or alignment, if there is limitation of movement of either limitation of conjugate gaze, or if there is nystagmus. So yung nystagmus, it's a condition where the eyes moves rapidly and uncontrollably. It can be side to side, down, in circular manner. So the movement can vary between slow and fast and usually happens on both eyes. So this is a sample patient using the corneal light reflex. You can say that one eye is centered. So in the first, or the uppermost picture, we have symmetrical light reflexes. For the second row picture, there is a mention of isodeviation. Can you tell me which eye is the eye deviated? How can I see yung participants here? So, Miss Aliana Jane Exala, is she present?
Yes, po.
Yes. Okay, so for the second row, the middle picture, how can you say it's isodeviated and which eye is isodeviated?
Doc, is it the
Yung right, yung left eye.
left eye?
Ito, this one.
Opo.
May deviation. Okay. Okay, si Miss Amulia Vana is present.
Yes, Doc.
Okay, so how about you, ma'am? Which eye is deviated? The right eye or the left eye? Remember, we're talking about corneal light. You observe the light reflex that falls on the cornea.
I think it's right, Doc.
For you, it's right. So, si Miss Aliana, why did you say it was the left eye that deviated? Still there, Miss Aliana. Exactly.
Yes po.
Bakit yung left? Ay, yung Filipina? Bakit left ang deviated? Easily. Not sure.
Not sure.
Si Miss, what's her name again? Amulia. Rana. Why right?
Doc, the light is not at the center, po. It's towards the right.
Okay.
The deviation, po.
Okay, so it gives you the impression that the right eye is actually towards the nose. Kasi yung light reflex, I'm pertaining to this. This is your corneal light. If you shine a light in front of the patient, you'll get this reflex. So you notice in this picture, wala siya, it's not in the middle, it's not on the center. Kaya nga the center light reflex. And it's isodeviated, meaning inwards. Kasi, because if the corneal light reflex is nandito in the middle, then that's central. If it's towards the temporal pupillary border, it means somehow that the patient is, so right eye is turning inwards. Okay? You get that? The same way, sa third picture, yan. So you look at the corneal light reflex, center sa left, sa right, it's nasally located, the pupillary border. So, yan. And yan. And the last picture is parang the eye is somehow parang deviated outwards. Kaya yung instead of center, nag-moving like this. Okay? Okay, so next is the 9 positions of gaze on your test. These are the directions in which the patient looks. Straight gaze muna, looking in front, straight at you, and then vertical, up, horizontal, yung left, right, and yung obliques. Upper right, lower right, same sa left side, upper left. Okay, so yeah. Ganyan. So let's call Miss Mildred for you. Hello. So, do you notice any abnormality in these pictures due to the setup? Call these plates. Can you say something about the pictures? We're talking about ocular motility, so you will have to observe on the movement of the hand. So do you ever do this? Have you ever handled patients where you check them or puro lectures pa? Lectures pa lang. Wala pang sample patients. Okay. So, sige ka na
Secret. So on the left plate po, Doc, the eyes can, yes po. The top one po, Doc, it can see all the way.
Okay, pretty abnormal. We're looking for an abnormality.
For the abnormality po, on the right po, Doc, on the right top. Hindi siya pareho, Doc. I mean like, one is in the middle, then the left eye po, all the way by the nasal border po, pero yung right eyes, hindi naman po.
Okay. Meron pa? Kasi magiging clerk na kayo, di ba? Third year kayo, tama? Tama ba? Third year kayo or clerks kayo?
Yes po, Doc.
Third year. So next year, you will be handling patients. Yan yung mga basic, no? Na kahit dapat na-test nyo na. Test. Anyway, Miss Mildred, UFC and Acuity. Okay, let's call Miss Micaela Grace. You see any other abnormalities? Wala siya. Miss Micaela. Ano pa? May nakikita ka pang ibang you see any other abnormal pictures then? Aside from
The right eye po in the dorsal pupil.
dito? This one or this one?
Upper right po.
Ito.
Up.
Yung pointer or my mouse. Can you see my pointer? Ito. Hindi. Okay, so anong napansin mo dito? O paano mo nasabing abnormal? You just describe.
Ang kasi po yung left eye po yung sumunod po dun sa first point instead of the right eye.
So, parang hindi nag-move ito. Okay. So, yun nga. Thank you, Ms. Micaela. These are your 9 positions. Okay, so first, you ask the patient to look in front. Do you see any abnormality? Wala. So, ask the patient to look up. From normal, look up. Normal. To the right, parang hindi, doesn't look normal. Tapos to the left, okay lang. Now you check your, yung oblique, movements. Upper right, still parang there's something wrong. Upper left, parang okay lang. Downward naman, down right, same lang, abnormal. Hindi siya going all the way to the right and down. Dito, dito, it's normal. So, you know na pag tumingin yung patient sa right side, hindi full yung ocular motility niya. Yung range of motion ng right eye is not moving. It's not moving all the way to the right. This is when the patient comes to you and complains of diplopia kasi iba yung nakikita nito this direction, iba naman nakikita nito this direction. Kaya dalawang image nakikita niya. Yan, pupunta yan sa guide. Patient will come to you and complain of double two images seen. So, in this condition, you will suspect ito yung muscle mo dito is your lateral. So, you have a right lateral rectus palsy. Yung etiology, yeah, pero most likely it's microvascular. Anyway, that's for the ocular motility. Now is the ophthalmology. So, evaluation of a patient with neurologic symptom is not complete without evaluation of the ocular fundus. So, special attention, since neuro-ophtha yan, so special attention should be given to the appearance of the optic disc. So, these are some the neuro-ophthalmic conditions that's so it may be swollen and elevated. Normally, you have a distinct margin. That's when you examine a normal eye and fundoscopy or ophthalmoscopy. distinct, kita mo yung borders niya. You can transition from orange to yellow or yellow-orange to red is distinct. And this other picture of the left eye, OS, swollen siya. Why? Kasi wala yung border o para siyang, let's just say, a plateau or a volcano. It rises up instead of parang excavation. Okay, so this is your normal. Again, this is your normal. If you see an optic nerve or disc like this, that's swollen. Okay. So color, good for the color. So the normal color is orange, yellow-orange, or a bit red. But anything less than that is pale na. Parang ito. Yan. So, papuntang white na siya. It's turning white. So that's pale and possibly because of atrophy, a long-term optic nerve disease. Okay? Ayan. If you spend more time, hindi yung mabilis lang, you spend more time and you really observe the optic nerve, you'll see there is a venous pulsation. So you also know for that. Kasi when there's no venous pulsation, it might be a sign of increase in the curve. This one, blue arrow points to a normal finding of a flame-shaped disc hemorrhage. It can be a sign of glaucoma. And of course, yung cupping of the optic nerve. So when I talk to patients, I like to describe the optic cupping, the cup disc ratio as parang donut. You have a hole in the middle and then you have a thick neuroretinal vein. So cup should be around if you divide this into 10 equal slices, 1, 2, 3, 10, it should occupy around 3 portions. So that's the normal size of the thing. Yan, I tell them, para siyang salvavida or parang donut. Pag glaucomatous or merong nerve problem, yan, the neuroretinal rim thins out. So instead of looking like a donut, it looks more like a bicycle wheel. Mas malaki na yung cup niya. Mas nag-widen. It means yung portion of this nerve here has already thinned out. Doon na lang yung natitira. So if this is around 0.3, maybe I could grade this around 0.7 or 0.8 na sa cup disc ratio. Okay? So that's the few things you examine in a patient. Now, let's try to discuss a little bit more about it. These are all just brief discussions kasi one single topic can really take up so much time. So let's just go through it, browse through it. If you have questions, let's see if we can answer it. No? Let's try and answer it. Something's confusing or parang hindi clear. So for pupillary disorder, you remember kanina, we tried to shine a light in front of the patient's eyes. And then, so, let's try to discuss yung pupillary disorders that you might elicit. So, first is yung dilated pupil. Okay, the dilated pupil. Usually, it's indicative of a loss of parasympathetic input to the iris sphincter. So, nagda-dilate siya. Alin ba yung pathway na involved? So, constriction is parasympathetic, di ba? PC, personal computer, SD card, sympathetic, dilates. So, pag loss of parasympathetic, nagda-dilate siya. Okay? This may be a result of oculomotor nerve paralysis, maybe atonic pupil, traumatic mydriasis, dorsal midbrain, and following can also be due to a prior surgery as the patient nagkakarap na ba kung saan na-touch yung ano niya, yung sphincter niya, ganyan, or go to surgery, filtrate surgery. Baka naman, maybe the patient has self-medicated and instilled drop into his or her eye, and you don't know it's a mydriatic agent, so it will really dilate. Kasi sometimes they just put in the drops without even knowing, but it's more, sometimes it has a dilating drop. So yeah, they come in, sasabihin nila, they say it's blurred yung vision. Kasi they examine the patient, it's dilated, doesn't react to light, and then you ask them, try to elicit, self-medicate sila. So, third nerve palsy, or the cranial nerve 3 palsy. We know that the cranial nerve 3 controls or exerts control over most of the eye muscles in the following muscles. So, when compromised, the following will result. The eyelid becomes droopy, this one, called ptosis. The pupil becomes dilated and poorly reactive to light. Yeah, this one is a little bit smaller than pupil here, so dilated. The eye loses the ability to elevate and press or move nasally. So basically, your eye is down and outwards, so down and out. That's cranial nerve 3. It can be, when you have a cranial nerve 3 palsy, it can be with the involved, it can involve the pupil, or it can also spare the pupil. For this picture, syempre, dilated siya, so that's you call that pupil sparing siya would be due to microvascular infarct, cause of diabetes, hypertension. If it's in pupil involving, it's most likely due to a compression of the superficially located parasympathetic. It can be aneurysm, space occupying lesion. So parasympathetics constrict, PC constricts your pupils kapag na-impinge siya ng something or a mass effect on it will cause it. I will lose yung constriction. So it will then. So when you have a compression or damage of the upper brainstem, it can cause a acoustic cluster of ocular findings known as the dorsal midbrain syndrome. So the syndrome consists of loss of gaze, convergence retraction nystagmus, light near dissociation of pupils, and it also may exhibit the collier sign. So this dorsal midbrain syndrome can be caused by, in children it can be due to acrobatic stenosis, meningitis, in young adults it could be due to trauma, maybe contamination. The elderly, vascular stents, aneurysms. Any patient with dorsal midbrain syndrome sign should yung light near dissociation means doesn't concentrate on light, pero when you ask the patient to look at something in front of his eyes, very, very near, straight. Aditonic pupil is another condition that presents with pupillary disorder. So it's a benign idiopathic condition, predominantly in young women and occurs unilaterally in in-person cases. The hallmark is a slow redilation after vaccination. So it is a disorder in which there is a parasympathetic denervation of the afflicted pupil. So let's see. So in this picture, this is a light source shown in front of the right eye, pero we don't see the pupils constricted. When you ask the patient to look at the near target, constriction. So you have a light near dissociation, resulting in a poor light constriction, but better and tonic near constriction. So this is what your anisocoria is unequal pupil size. So this is a case of anisocoria that is greater in bright light. Kasi in a bright setting, this normal eye will constrict. It will not appear or will not react to the light source. So yeah, it will stay or parang slowly lang siya. So makita mo, you can see that there is anisocoria. If it is, it presents with diffuse hyperreflexia or poor deep tendon reflexes, you call them bones. Just that's the normal. For Argyll-Robertson pupils, they sometimes call this the prostitute pupils because of their association with tertiary syphilis, no? And also because of the characteristic of the pupils that it accommodates but does not react. So parang same siya with Addis, no? Accommodates ibig sabihin. You look at the near target, nag-ano siya, constrict, pero shine a light, it does not react. So for Argyll-Robertson pupils, it is characterized by small, irregular pupils that have little to no constriction to light and constrictiously briskly to near targets. Any patient, Argyll-Robertson pupils or adistonic pupil should have an MRI and should be tested for syphilis kasi they have association with neurosyphilis. So, in here, kanina in the aditonic pupil, dilated siya. Ito naman, small lang siya, small irregular pupils. Pero mas malaki or the pupils are a little bit bigger dun sa abnormal. Although it's not that dilated. Then when you ask the patient to look at near target, the constriction, the pupils become even smaller, like pinpoint pupils. So that's the difference. Okay. For Horner syndrome, now we go to Horner syndrome, which is caused by a dysfunction of the sympathetic pathway and presents with ptosis, small pupils or meiosis, and hydrosis. For congenital cases, mayroon hydrosis. So, ptosis and ptosis ng Horner syndrome is upper and lower. Okay. Miss Shaina, Sophia, and Brada, are you here? No? Shaina. Yeah, right or left eye, which one is alarm? And can you point out the abnormalities? Just describe. Drooping back. You're parang nag-break ka. Did you say drooping of the left
Yes po.
eyelid?
Yes po.
Ganun ba? You look closely, yung pupils niya, ito, miosis, myotic, small. Ito, normal. Sabi mo na. Okay? And anhidrosis is yung loss of the ability to sweat or perspire. So it's the left eye. So ptosis, meiosis, and yung anhidrosis. So for this syndrome, it's anisocoria that is greater in the dark. Paano yun? So you have meiosis. So you go to a dark place, yung normal eye, na it will dilate. But this, meron kang meiosis, constricted siya. So you see yung kasi when you shine a bright light, magko-constrict yung normal eye. Same as yung myotic pupil ng left eye. When you go to a darker place or a dim affected eye na may presenting with Horner syndrome will remain constricted and the normal eye will dilate. So it's an isocoria, case of an isocoria that's greater in the dark. It says dilation lang. Kasi for Horner syndrome, it doesn't stay naman constricted. It dilates pero at a slower rate. Kaya may dilation. Okay? So, yan. Here are some life-threatening lesions that can present with Horner syndrome, carotid dissection, cavernous carotid aneurysm, and apical lung tumor. Why? Because this is where your pathway passes through. So if you have conditions like this, it can affect or present with Horner syndrome. Ngayon, Panco's tumor, apical lung. You have excuse me, problem in your cavernous system. It will impinge on the. This is already your third order neuron. It will also present as Horner syndrome. Okay. So how do you test for it? You do the Abrupt test. Is the more widely used test kasi more available. So when you have Horner syndrome, you have meiosis and ptosis. Give the Abrupt test, which is also used for glaucoma patients. There is a reversal of the meiosis and ptosis. That's positive for syndrome. When you do the cocaine test, it dilates the normal pupil, and then yung normal pupil remains constricted. Those are the two tests. Meron pa isa yung hydroxymethamphetamine test, but that's more on localization. First order, big central, preganglionic. So yun yung sa mga pupillary disorders. Let's go to motility disorders. Kanina we mentioned double vision or diplopia. Third nerve palsy, ayan, palsies, third, fourth, sixth, ANO, MG, and Alzheimer's. Let's see what we discuss about that. So double vision or diplopia. So sometimes yan, with counter patients nga coming into your clinic and will complain of double vision. So after a thorough neurologically oriented history, you differentiate if it's binocular diplopia or monocular diplopia. So the true binocular diplopia, you have two separate images. So when you cover one eye, the diplopia is relieved. The patient doesn't see a double vision. Pero monocular diplopia, it's a double vision within one eye. So it will not relieve the patient even if you cover the fellow eye or which eye. So pag monocular diplopia can be usually due to refractive error, can also due to dry eye or Third, nerve palsy. Cranial nerve. You already know that cranial nerve 3 controls a lot of muscles in your eyes. Following are such, no? So, yun nga, complete paralysis produces horizontal, vertical, diplopia. Ptosis of the upper lid. Inability of the eye to move inward, upward. Pupils may be dilated. So, looking for this, let's call again. This time, si Shock San. Shock is tell me, what are your observations for these pictures? Where can you find the abnormal?
There's a weakness on the left side. On the left side.
Right side and left side.
Yeah.
There's an weakness
on the left side. You can see on the left middle. There is a drooping of the eye.
This one? Or ito?
On the left side.
Ito, left side. Ito. You mean this one? Ito.
Yes.
Hindi. Pilipino ka.
Yes po daw.
Tingnan mo to. Tinutulungan na siya ng ano. The examiner is already helping the other eyelid to raise it up. Kasi nga, coating siya. It's depressed. Parang nakababa siya. So, you have to help the patient to open it. So, it means ito yung abnormal. Ito yung this is the straight gaze, the primary gaze. So, ganyan na yung pasyente. So, looking at this primary gaze, alin yung may problem? It's that right. You notice, di ba, third nerve palsy, 3, 4, 6, 3, 4, at saka, and then, cranial nerve 3, inferior rectus, yan. Kaya it's down and out kasi nga, walang medial rectus movement, hindi siya elevate and it stays down there. And your cranial nerve 3, remember, is also responsible for opening the eyelids. So kung meron kang cranial nerve 3 also, so the eyelid will move and your eyes will position down. Okay? Common causes of isolated third nerve palsy is cranial nerve, intracranial aneurysm, especially of the posterior communicating artery, microvascular infarct, within the nerve, through diabetes and hypertension. If you have no evidence of microvascular disease, then imaging and should be okay. Fourth nerve palsy, a patient with a fourth nerve palsy complains of vertical double vision. So, instead of magkatabi yung nakikita niya, dalawa, sees the patient sees two images that are one on top of the other. Vertical. So, for this condition, dito letter A, this picture enclosed in a red rectangular box is your straight or primary gaze. Straight gaze. You notice, kung nakabilaw, yung right eye niya is hypertrophic, elevate. So, as the patient looks to the left, the hypertrophy increases. Now, to decrease his double vision, it tilts his or her head to the left or the contralateral gaze. Tilt kasi when you tilt your head to the same side of the palsy, it will even increase the double vision, like the one in this picture. Okay? From this original. What's that? Is the student talking to me or? Anyway, so ito, from straight gaze, tapos right tilt siya, then na-notice niya, mas nag-increase yung ano niya. Can we tell Mr. Sharan? Yes. Okay, so meron ditong actually SGE or Sargent. So straight gaze, you notice there is already a normality of the right eye. You know na yung pwedeng palsied eye. Yung contralateral gaze, it even worsens. And then yung head tilt to the same side also worsens. So you can consider four-third palsy. So if unilateral cause maybe microvascular disease, if bilateral. For the occlusive nerve or sixth nerve palsy, you know that this supplies the lateral nerve. And na-discuss natin ito kanina sa yung ocular motility. No? So in this picture, you notice so straight gaze, primary gaze, normal, up, down, normal. Start patient to ask right gaze, left gaze, normal. Ito parang limited. Check on the upper and lower, ganun din. Wala siyang lateral movements. So you consider sixth nerve palsy. So paralysis that produces loss of abduction that may result in horizontal myopia. The greatest separation of images is when the gaze is toward the affected side. So, hindi siya makatingin. If the patient cannot look to the right, then yun yung affected side. Microvas. So you consider a cause of microvascular. This is caused by microvascular disease when patients are older than 5 years age. But with that, we can initially manage patient as observation that we know that in 3 or 4 months it will recover spontaneously. If not, the patient follows up, then you can start. For lesser than 45 years old, MRI is indicated initially because the incidence of occupying vision increases with increased vision. Okay. For children, trauma is the most common etiology. Other causes can be infectious disease, post-viral, inflammation of the petrous ridge from severe otitis media. So you can ask the guardian or the patient directly about head trauma, recent illness, vaccinations, period. Then if they're not present, also do new images. Okay, so I into internuclear ophthalmology. So this is for yung conjugate. So when you ask the patient to look to your left, both eyes move to your left. At the same time, when you ask the patient to look to your right, both eyes move to the right. No? So in internuclear ophthalmoplegia, the medial fasciculus here, or the a lesion of the MLF interrupts the connection and manifests clinically as an INO. So from the six nerve nuclei, it synapses to the contralateral third nerve nuclei to innervate the medial rectus. Yung sixth nerve innervates the lateral rectus. So when you interrupt that, the patient will manifest with slow or weak adduction of one eye, and then nystagmus of the abductive LI and abductive. So when you ask this patient to look to his left, hindi siya nag-move all the way to the left, and then the other eye presents with a nystagmus, yung jerky to and fro movements. So parang nag-quiver siya as he looks to the left. And that's what you call internuclear lesion in the MLF, or the medial longitudinal fasciculus. For older individuals, INO may be due to brainstem or brainstem microvascular disease, or and it typically recovers in weeks or months. For younger adults, most commonly due to a demyelinating disease with brainstem hemorrhage. In children, it may be due to all patients with INO should have an MRI. NG, myasthenia gravis, a chronic autoimmune condition that interferes with neuromuscular transmission and skeletal muscles, characterized by abnormal fatigability of skeletal muscles after repetitive contraction. So it worsens as the day progresses, and will be improved by rest. So presenting signs of myasthenia gravis is also ptosis and convolution. So for ocular myasthenia, only ocular signs are present, and you know that 50% will develop generalized myasthenia in 2 years. So the diagnosis is usually established clinically, and to test for it, you may do serologies for acetylcholine receptor antibodies, electron IV hydrophonium or neostigmine, ISPAC test, or the sleep rest test. The ISPAC test and sleep or rest test you can do with med students. For ISPAC test, you just put an ISPAC on the photic eye, the affected eye, for 2 minutes, and after 2 minutes you will see parang it improves yung eyelid function of the ptosis disappears. Same as for the sleep rest test. You ask the patient, do you manifest with drooping eyelids when you wake up in the morning, or just towards the end of the day? So pag patient tells you, oh, when I sleep, parang it goes away. So that's a sleep test or rest test. So this can be treated by myasthenia gravis condition by reduced techniques, systemic steroids, other suppressants such as aspirin and classic medicines. This is nixtamals na. This is spontaneous with back and forth movement on both eyes. It can be horizontal, vertical, or inclination. The 3 most common forms, first, second, or cause of lateral gaze, dun siya represent. But second form, it is induced by medications. So, ito, not just the lateral gaze. The second form may be present in all positions of gaze. Third form, usually congenital siya. It's a pendular or chirping beating nystagmus. So parang yung pendular, this one. So parang clock. So congenital yun, they got used to it. So there is no complaint of synapse. They have some condition. Yung acquired nystagmus, that is the type of nystagmus that causes oscillation or the patient with dizziness. So for these cases, pag acquired yung nystagmus na, meaning she or he didn't have that before, and when you examine meron siya, you consider peripheral vestibular disease. Can be due to trauma, sclerosis, brain tumor, degeneration of the CNS. If there is no peripheral vestibular disease, then you will have to do a full neurological evaluation and MRIs for it. So, yun, generally, pathologic forms of nystagmus are usually detected in primary straight ahead position. So, we don't even have to ask the patient need the 9 positions of gaze. Just straight gaze, primary gaze, and already observe the nystagmus. Okay, now we go to that disc elevation. We also have come across this kanina of yung optic nerve elevated, swollen. So these are the following conditions that may present with optic disc elevation. One is congenital disc elevation. This is a normal variant. It means benign lang siya. May be accompanied by the presence of bright yellow proteinaceous material with the optic, within the optic disc itself, meaning through section. So, hindi siya talaga elevated or swollen, hindi meron lang deposits, proteinaceous material. So, the right picture is, however, the true papillary. So, yung left, this one, optic disc lucent represents like this elevation is actually a pseudo, meaning it's not true. Swelling of the okay. So papilledema, this is a swelling of the optic disc secondary to increased cranial pressure. Endoscopic characteristics are hyperemia of the disc, tortuosity of the veins and capillaries, blurring and the elevation of the margins of the disc. So, usually wala ka na. Margins dyan, obscured. And even the retinal vessels near the bulb are seems like obscure in these distinct. There are hemorrhages surrounding that. That's endoscopic characteristics of so typically dapat bilateral pero asymmetric. Siyempre not exactly the same. Initially, the vision is not good. So, symptoms will be associated. Symptoms will be headache, nausea, fatigue. So, what are the causes? It can be due to brain tumors, idiopathic intracranial hypertension. We'll talk about that in the next slides. Cerebral trauma or hemorrhage, meningitis, and encephalitis. So you treat this by treating the endocarditis. Okay, papillitis, inflammatory edema of the disc. Looks like papilledema din. Ayan, ophthalmologically indistinguishable from papilledema. But this one is commonly unilateral. Ayan, tapos, yung papilledema, initially hindi siya affecting the vision. acuity. This one is associated, papillitis is associated with decreased visual acuity, impaired color vision, and visual field defects. There is an RAPD. So this condition may result from ischemia, infiltration, compression, demyelination. Okay. So IIH or idiopathic intracranial hypertension can produce papilledema as mentioned a while ago. So this is due to an increased fluid pressure around the brain in the absence of other abnormality, which usually occurs in women around 20s to 40s with recent weight gain. Hence yung picture, parang obese female in their young years, 20s to 40s. So, symptoms of pseudotumor cerebri, yan yun, headache, transient blurring of vision, visualitis, horizontal vision, neck stiffness, vision loss, pain with eye movement. So, yeah, signs are often limited to edema. So, you ask if there are history of steroids, vitamin A, retinoic acid, methamphetamine, or its derivatives added. So, workup is brain MRI and lumbar puncture, opening pressure, and CSF profile. I think, yeah, diagnostic yung LP, lumbar puncture, at the same time therapeutic. Kasi yun, the treatment is actually decreasing the intracranial pressure. Of course, you ask the patient to do a weight loss, lose some weight. You can give carbonic anhydrase inhibitors, CSF shocking procedures, and but you don't do that with surgeons. Okay, ito, the more common ones na are, anyway, dito pala sa IIH, hypertension or so vision loss is the most dreaded consequence of this condition kasi yung chronic papilledema arising from increased intracranial pressure may result in progressive ganglion cell death because of compromised axonal hemostasis or ischemia. It's also important to treat optic neuritis refers to inflammation and demyelination of the optic nerve. This is usually occurring in women, same as yung IIH, 15 to 45, around that age. So, patient will present with an acute or subacute vision loss associated with periocular eye movement, pain on eye movement. Okay. So, the visual acuity presents in a varying degrees. There is impaired color vision and there is visual acuity. So overall, 50% will ultimately develop sclerosis. You can do an MRI with flare sequences, and if it is positive for lesions, then you can you can say that there is a higher risk of diabetes. Right? For typical optic neuritis, the vision will recover spontaneously within weeks, around 2 weeks. Pero we still give treatment kasi it hastens the recovery. And it decreases the rate of occurrence in the eye. Okay? So the treatment for optic neuritis is 250 milligrams IV methylprednisolone Q6 or 4 times a day for 3 days. Then 1 milligram per kilogram of prednisone tapered for 11 days. IV for 3 days, high dose, methylpred, and then oral pred tapered for 11 days. Yung oral corticosteroid alone or solo therapy are contraindicated kasi it poses a higher risk of overdose. yung sa ischemic optic neuropathies, it is one of the important causes of acute vision loss in adults. So it results from microvascular infarction of the optic nerve. So there are two major variants of anterior ischemic optic neuropathy, the arteritic and the non-arteritic. Of the two, yung non-arteritic anterior ischemic optic neuropathy occurs in patients who are 40 years old and above. So there are atherosclerotic risk factors when you ask the patient. Most likely has hypertension, EM, hyperlipidemia, is smoking, has episodes of sleep apnea, and maybe obese. So this is probably due to a transient hypoperfusion of the optic nerve. So unilateral vision loss is first noted upon waking up. You can work with a patient, complains of waking up because pangit yung visual acuity or loss of vision na, then we consider this above 40 years old and with risk factors. So eye exam, you have a poor VA, there is an RAPP, and the disc is edematous initially. So under optic disc elevation. Treatment is aimed at risk factors. For the arteritic anterior ischemic neuropathy, this is sudden, painless, and often catastrophic vision loss in older patients, maybe greater than 50 or 60. Early recognition is critical since this can lead to blindness, iritis, and even strokes. The fellow eye will follow rapidly often within days, if not promptly, then aggressively. So the most specific clinical features are jaw claudication, new onset headache, visual abnormalities like amaurosis vulgaris, diplopia, and vision loss, and palpable temporal artery abnormalities. Meron din po yung parang scalp or tenderness. So you have a patient doesn't parang messy hair, tapos in pain, most likely, tapos elderly, you can initially consider GCA or giant cell arteritis or arteritic anterior ischemic. This one, high clinical suspicion. And you do workups, ESR and CRP elevated. But the diagnosis is made by temporal artery biopsy. Okay? So the goal of treatment is actually protection of the other eye. So you start on corticosteroids immediately and schedule for a temporal artery biopsy while waiting for results. So this is a table to parang simplify the three most common cases that causes optic disc elevation. Optic neuritis, non-arteritic, tsaka yung arteritic anterior ischemic optic. So for 20 to 40, female, most likely optic neuritis. 45 to 65, non-arteritic, yung mga may comorbidities like diabetes, hypertension, tapos wakes up. Suddenly may loss of vision, non-arteritic. Pag arteritic, mas matatanda, more elderly patients, greater than 65, yan. Tapos meron silang scalp pain, weight loss. Yung disc nila pale, yan, so arteritic. For this one, yung non-arteritic, you do a perimetry study, yun yung test for visual fields. One of the is yung altitudinal field view. So this is characteristic of non-arteritic anterior ischemic. Kasi for optic neuritis, it can be any. And same for arteritic. So ito, for non-arteritic, it's altitudinal. Okay? So this is a summary of the most commonly encountered optic disc elevation. Okay, for visual field defects, ito, it means yung parang meron siyang stopomas, no? yung parang blind spots. So you can do this through perimetry study or yun nga, yung confrontational field testing. Pero the thing is when do you do it? Sometimes kasi when the patient comes in, tapos sasabihin, they will tell you there's blurring of vision. Pero not all patients are good in describing their blurring of vision. Basta some of them will just say, basta it's blurred. Basta I can't see clearly. Others will tell you talaga. They will describe very well. So, pag the patient comes in and tells you, I have blurring vision, might as well do confrontational field testing sa clinics and you elicit somehow a positive or a field defect, then you confirm it with perimetry. So yun, yung scotoma is an area of abnormal or absent vision within an otherwise intact vision. When you say hemianopia, it's loss of half of the visual field. Tapos, homonymous hemianopia, loss of half of the same side. So, both right side, the half, that's homonymous. And bitemporal hemianopia, half, but on both sides. I mean, outer sides. So, bitemporal. Okay? So, yun nga, yung patient will come in and say, I have a blurring of vision. I have a problem with my eye. So, you do the confrontation. Tapos, you see that parang meron positive na blind spot or scotoma. So, we can group this findings into lesions that are anterior, with respect to the chiasm. It can be anterior to the chiasm, within, or adjacent to the chiasm, or posterior to the chiasm. So, when lesions are anterior, this is localization na using visual field. Kunyari, na-elicit mo, itong right eye niya, fully, walang makita, cannot see fully, and the left eye is okay. So, you can localize where in the visual pathway can the lesion be. So, yan, lesions anterior to the chiasm, ipsilateral eye only ang may visual field defect. Can be, the defect can be central scotoma or altitudinal hemianopia, and with accompanying afferent pupillary. So, most common causes of unilateral optic neuropathy, yun, optic neuritis, papillitis, ocular glioma, meningioma, and ischemic optic. Okay, now affecting the optic chiasm or within the optic chiasm, in red part lang, it will present with visual field defect by temporal and erosion. Only the sides can see. Parang horseshoe vision, may cover yung sides ng periphery niya, so yung center lang. So this is most common. The causes can be pituitary adenoma, craniopharyngioma, and paracellular meningioma. Another lesion affecting the optic chiasm, or another visual field defect that will present when the lesion is affecting the optic chiasm is your junctional scotoma. Junctional scotoma is another loss of central field or full field in one eye, or some central lang dito lang, parang not, yung periphery is intact, no? In one eye, and temporal visual field defect in the other eye. So, this is a junctional scotoma. It's a lesion that's located somewhere here or here. Okay, now when you have posterior to the chiasm, lesions found posterior to the chiasm, you can present with upper homonymous hemianopia. Tawag natin dito, we call this pie in the sky. Okay, so temporal pie in the sky, upper homonymous like a quadrant. You have a temporal lobe lesion. You can localize it in the for parietal lobe lesion. Lower naman siya. So, pie in the sky, upper homonymous, lower homonymous, pie on the floor. So, it's parietal lobe lesion. So, for your mnemonic, parietal, pie on the floor. Okay. Tapos, ito na sa may visual cortex, occipital lobe lesion, it will present with hemianopsia pa rin. Hemianopia, but with macular spread. Okay, so, yung center of lesion is, this is some because of the dual blood supply. Even if affected yung one blood supply, there's still another blood supply that will, or a collateral blood supply that will supply the center macula. So it can still function. So another thing pala is the more posterior to the chiasm yung lesion, the more congruous. Parang the more identical yun. So closer to the chiasm, same side pero less congruous. Okay? So the most common cause of homonymous hemianopia are stroke, trauma, and past lesions. Okay, that's it. Okay. So, do you have any questions before we go?
No questions for me.
Okay. Si Stephanie Ocal, nandito ba siya? Wala? Stephanie Ocal, absent? Okay. Surya Prakash.
Yes, Doc.
Okay, you have a visual field defect na pie on the floor. Where can you localize the lesion? Where in the visual pathway, most likely can you find the lesion if you have a pie on the floor. So it's a quadrantanopia, visual field defect, homonymous quadrantanopia. Parietal. Pie, parietal. Pie on the floor, parietal lobe. You're doing this kasi you know that the eye is intact and the problem is up there in the head, in the visual pathway. So you're actually localizing the lesion where it might be occurring so that you have a clue when you refer it to the neurologist or to the surgeon for further management. You have at least localized where the lesion will help him out to find where the problem is. Okay, Shivani Goswami. Are you there? No. Shilnor Reyes.
Yes, po.
Okay. Pie in the sky. Where is the lesion? Where can you localize the lesion?
Temporal.
Hindi temporal, it can be occipital. Pero most likely temporal. Kasi sa occipital it can occur kasi paglikod na yun. Okay, yung junctional scotoma, where can you find the lesion is Papay, Elmira. Not here. Vishal, the tumor.
Yes, Doc.
Where can you localize the lesion if you do the confrontational field testing or the perimetry study? You get a result of a junctional scotoma. Anyway, can you describe junctional scotoma first? No idea. Let's see.
DML of the optic nerve.
Okay. At what level? Yung lesion? Is it exactly on the optic nerve?
Optic chiasm.
Ito. Where, kung saan nagde-decussate yung fibers. Yan. Junctional scotoma. Not exactly on the optic chiasm, pero near. They say it's one. Kaya ganito yung presentation niya. One eye affected and made temporal, superotemporal visual field defects sa kabila because of, you can look this up, von Willebrand knee. It's due to the distribution of the fibers here. Bakit hindi parehas? Because of the distribution of the inferior and the superior fibers that are being impinged of by the lesion. Okay? So it's almost 3 o'clock. If you have no more questions, then that is it. Okay? No more questions? I need someone to answer. Okay. So, I see. Okay, so that is it. No more questions. Bye.